Hi guys, just about to start the teach to share my screen, and then hopefully we should be okay to go. All right, guys, sorry about the delay. Hopefully, you can see that now. Just give me a wave or give me a shout if you're able to see that. Okay, are you guys able to see that? Okay. I'll just give it a few more moments and then we'll make a start. All right, so we'll make a start, guys. So welcome to the third in our series of neurosurgery conditions, hosted by myself on Mind the Bleep. Today it mentions about neurovascular, but I specifically want to talk about kind of more neurotrauma, which is the main topic you come across a lot of the time. Really, is a subarachnoid hemorrhage, and oftentimes this is quite possibly one of the most devastating conditions that you can see in a patient that's probably referred to you or to the neurosurgeon on call. The main things to take away from today's session, really, we're going to keep it quite brief and quick because it's quite a massive topic. So honestly, we can spend the whole day talking about it. But what we're going to do is just going to kind of have a brief whistle-stop tour of subarachnoid hemorrhages and some associated stuff with it. So the first thing is, what is a subarachnoid hemorrhage? So essentially, it's a very simple way of putting it. It's a bleed in the subarachnoid space, which is obviously the space between your arachnoid and your pia mater meningeal layers. So you might be thinking, what are those layers and what are the meninges? So when you actually look and you think about the brain, the brain is such an important organ that it's encased in three meningeal layers. Okay, and these meningeal layers are basically protective coverings of the brain. And what they do is they adhere to the surface of the brain and actually the spinal cord. And there are three meningeal layers. So you have the dura mater, which is your outer layer, which is quite kind of fibrous and thick and quite heavily vascularized. You have your arachnoid mater, and then you have your pia mater, and that's the order kind of from outside to in. So your pia mater is really closely adherent to the surface of your brain and your spinal cord. The subarachnoid space, really, it's in the name, it's subarachnoid, so it's just below the arachnoid. So it's found between the arachnoid and the pia mater, which is kind of the two layers deep to the dura. There's lots and lots of blood vessels that run between these layers. And actually, in this space, not only do you have multiple vessels in that space, but actually it's, includes the circle of Willis, which is an arterial polygon in your brain, which is basically your main arterial supply to the brain. But that's a kind of definition of a subarachnoid hemorrhage. It's just bleeding into your subarachnoid space, which is part of your meningeal layers. So there's three meningeal layers, the dura, arachnoid, and the pia mater, and it's bleeding that occurs just below the arachnoid. It's typically seen in patients of the age group of 55 to 60, but you must also remember that it can happen basically in anybody because of from trauma, really. Subarachnoid hemorrhage is actually the most common cause of a subarachnoid hemorrhage. But that's that. So in terms of the etiology, so a subarachnoid hemorrhage, you can split them into two. So you have traumatic and spontaneous. Subarachnoid hemorrhages, just before we even talk about that, it's important to note that about 10 to 15% of all patients actually die before they even reach hospital, some literature state. So that just shows you how catastrophic it can actually be, a subarachnoid bleed. And actually, these patients usually need to be managed even before they've got into hospital, because they often can just be so unwell, and they can have present with a reduced GCS and airway issues and all sorts of things that can present even before they've come into hospital. But going back into the etiology, so it's divided into traumatic and spontaneous. So traumatic subarachnoid hemorrhages are the most common cause of a subarachnoid hemorrhage. And actually, it's in the setting of things like a head injury. So let's say somebody's had a nasty fall, or they've been assaulted kind of with a baseball bat, or even a road traffic collision, a high-speed road traffic collision. Those are usually the most common cause of a subarach. A spontaneous subarachnoid hemorrhage is usually due to the rupture of what we call a cerebral aneurysm. And we'll talk about that a little bit later on. But essentially, a cerebral aneurysm can oftentimes, in spontaneous hemorrhage, cause a subarachnoid hemorrhage in that case. And they're not as common. So going to a traumatic subarachnoid hemorrhages, usually you'll get a lot from the history. So oftentimes these patients, you'll need a collateral history, because essentially they've come in and they are, they're obtunded, they have a reduced GCS. You can't really take a history from them. They may be intubated and ventilated. So like I said, these patients can be really unwell, and so oftentimes you'll actually find that you're taking a history from their next of kin. More on the subject of trauma. So a lot of the time, because of the trauma these patients face, they actually have coexisting injuries. So they have a intracerebral hemorrhage or an extradural hemorrhage. And usually with trauma, you can actually see that there is a spectrum. So oftentimes I've seen people come into A&E with a mild subarachnoid hemorrhage, even from trauma. And usually they can have a better prognosis, let's say. But obviously it is a spectrum, and there's patients that are right on the other end of the spectrum, and they have other associated, like I mentioned, intracerebral or extradural hemorrhage, and they oftentimes can have really poor prognostic outcomes. In terms of the other cause, so the less common cause of a subarachnoid hemorrhage is a spontaneous. So in about 75 to 80% of spontaneous subarachnoid hemorrhages, it's usually because of the rupture of a cerebral aneurysm. So does anybody kind of have any idea of a cerebral aneurysm or anything like that? Just put it in the chat. Well, that's fine. I'll just explain. So an aneurysm is basically an abnormal dilatation of a blood vessel, as you know, typically by more than what we say 50% of normal diameter. So aneurysms can happen anyway, and I think the approximate prevalence of intracranial aneurysms in the adult population is around 3%. So oftentimes it's quite sad. You can have patients that come in with a spontaneous subarachnoid hemorrhage, and actually you realize it's secondary to the rupture of a cerebral aneurysm that was previously undiagnosed. Aneurysms cause most of them, and they usually are formed at the sites of where blood vessels bifurcate or merge. So we'll come onto it in a bit, but essentially, I'll just quickly flag up this picture. Aneurysms are going to be where you get these vessels kind of bifurcating or merging, and a lot of them happen around here, which is the circle of Willis. And that's because obviously you have this complex arterial polygon that has branches merging and leaving, so it's very complex. And so you can see there's kind of sites of bifurcations and merging, and this leads to kind of differences in hemodynamics and blood flow and turbulence, and oftentimes can be the site of a cerebral aneurysm. And actually, most cerebral aneurysms, about 90%, are defined as what we call a saccular aneurysm, and the rest of them are fusiform. So if you kind of look at some pictures of it, but saccular aneurysms are kind of described as berry-like. They have a very particular shape, and you can even classify them by size. So you have quite small aneurysms, which are less than 10 millimeters. You have large aneurysms, which are 10 to 24 millimeters. And then you have giant aneurysms, which are typically classified as kind of over 24 millimeters. So you can just imagine the size of the aneurysmal rupture. So if somebody has a rupture of a small aneurysm, it's going to be a lot more amenable to, let's say, neurosurgical clipping, as opposed to, let's say, somebody who's had a really large cerebral aneurysm, the patient's had massive intracranial hemorrhage, they're hemodynamically unstable. You could just imagine the kind of outcomes that patient's unfortunately going to have. And with aneurysms, oftentimes the risk factors are things like kind of being of the female gender, hypertension and smoking are two really, really, really big risk factors in aneurysms. Another couple of things which I'll kind of put in risk factors are things such as autosomal dominant polycystic kidney disease, which is a kidney disease that some people get, where they kind of have the tendency to have lots of berry aneurysms. There are other things as well, like connective tissue disorders. So we've got, type 4 Ehlers-Danlos, you've got Marfan's. These all predispose you actually to having aneurysms, and essentially predispose you then to having a spontaneous subarachnoid hemorrhage. And an interesting point, actually, just talking about, let's say, family history, like I mentioned here, but actually, approximately 30%, patients are approximately 30% more likely to develop an aneurysm if a first-degree relative also how big of a risk factor the family history is. Bang on, Alex. Well done, Alexander. Exactly. So I've seen in the chat you put berry aneurysms. Exactly. So these can be really nasty things, and oftentimes you actually see patients come into the emergency department with headaches, or maybe even asymptomatic, and they have a CT head done for another reason. And sometimes you'll find an incidental aneurysm. So it's always really, really important to follow those patients up, and to make sure they have the appropriate screening for their aneurysm. And typically, there's different things you could do. So you can have surveillance and things like that. So that's typically how you'd monitor or how you'd manage them. It's kind of monitoring, every couple of months or years, depending on the neurosurgeon, and you want to assess for any progression in size. So that's that. I hope that's pretty clear. So a quick kind of overview. We've talked about subarachnoid hemorrhage and the different types, and most of them are traumatic and some of them are spontaneous. We've talked about traumatic kind of things associated with road traffic collisions, and we've also talked about how spontaneous usually are due to the rupture of cerebral aneurysms in around 80 to 90% of cases. And that's kind of where we're at the moment. In terms of the clinical features, so the subarachnoid hemorrhage typically presents with what we call a thunderclap headache. So oftentimes these patients come in and they describe it as the worst headache they've ever had, the worst headache of their life. It's such a bad headache. It's excruciatingly painful, and actually it reaches maximum intensity within seconds. So oftentimes just within a flash, they develop this horrendous headache that they describe as the worst they've ever had. And that typically itself, a thunderclap headache, really, really should make you very, very suspicious of a subarachnoid hemorrhage. So the main signs and symptoms, especially symptoms-wise, it's mostly going to be a headache and signs of meningism, which meningism is a triad that we typically attribute to what we say a headache, neck stiffness, and photophobia. So it's a triad where it's called meningism, and it's typically associated with either subarachnoid hemorrhage or, as you guys know, also meningitis. And it's a triad that you could say indicates that there is some meningeal irritation. Okay, so some meningeal irritation. It means that there's something, whether that's blood or whether that's even an infection. So these things usually make you very, very suspicious for either a subarach or a meningitis. So in terms of symptoms, just always think about a headache, neck stiffness, photophobia, and also things like nausea and vomiting, which are kind of a sign of raised intracranial pressure. And that might actually indicate that this patient has a big bleed in the brain, and hence why there is raised intracranial pressure. Other signs of meningism. So, Alex, do you know any other signs of meningism? So typically, maybe let's say some signs you could do at the bedside. I think there's two classic tests we talk about. I'll just see if any of you guys can guess. Just pop it in the chat. Yeah, so there's two signs you can think about. So one of them is called Koenig sign. Koenig sign is basically when the patient is unable to fully extend their knee when you flex their hip to 90 degrees. So imagine just having a patient lying flat, okay? You flex the hips to 90 degrees, and then as a result, they have an inability to fully extend the knee when you passively move it, and that's because of meningeal irritation, okay? That's Koenig sign. You then have something called Brudzinski sign, which is basically when they spontaneously flex their knees and their hips on active flexion of the neck. So imagine they're lying flat and you flex the neck, you'll then realize that actually they begin to involuntarily, and what we say spontaneously, just flex their knees and hips. And those are two classical signs of meningeal irritation. You can see them typically in a bacterial meningitis or a subarachnoid hemorrhage, but you must remember that absence of these signs do not exclude either of those diagnoses. So it's really important that even though you might see a patient has Koenig or Brudzinski, just because they don't, doesn't mean they don't have either meningitis or, in this topic, subarachnoid hemorrhage. So those are the clinical features. Coming on to something called a third nerve palsy. So third nerve palsy is basically, so the third nerve, what is the third nerve? The third nerve is the oculomotor nerve, and it's got a very important motor function to the pupil, as well as the eyelid, as well as the extraocular muscles. So third nerve palsy, really, if you have somebody that, let's say, going back to these signs, let's say they have a drooping eyelid or they have double vision, that's a really, really important sign. And actually, if they have an acute third nerve palsy, meaning they've got double vision, like I mentioned, or their eyes down and out and a droopy eyelid, then you just look at the eyes and it just doesn't look right. That is very, very concerning for what is a potentially enlarging aneurysm with a significant risk of rupture. So why does a third nerve palsy indicate that this patient might have impending rupture? Well, that's because of the fact that actually, when you look at the oculomotor nerve, okay, so the oculomotor nerve, it's all to do with the pupillary involvement, okay. So the parasympathetic motor fibers associated with your pupillary light reflex, which we know is important in your oculomotor nerve, they are situated superficially, so kind of on the outskirts of the nerve, okay. So the parasympathetics, okay, controlling your pupils, are located around the outside of the third nerve, okay? So if you have a large compressive lesion, particularly, let's say, an aneurysm, okay? If you have a large aneurysm, because this is compressing your third nerve, what it's going to do, it's going to compress the fibers around your third nerve, leading to pupillary dilatation and loss of the light reflex. And why is that? If you've got those parasympathetic fibers that usually control pupillary constriction, and now you're pressing on that, now you can't have pupillary constriction, so you're going to get the opposite. So you're going to get a dilated pupil. And so we say a pupillary dilatation, or fixed and dilated pupil, or what sometimes people might say a blown third nerve or blown pupil, oftentimes means you've damaged or you've affected those superficial parasympathetic fibers. And as a result, you may actually, that could be a large aneurysm. Does that make sense? So it's really, really important that anybody that comes in and they have a down and out pupil, you must escalate this as soon as possible. This is really, really concerning. If their eyes down and out, they could easily have what we call a third nerve palsy. Okay, so I hope that makes sense. Any questions, guys? Just put it in the chat, or even shout it out. No worries at all. So I'll wrap it up now and focus now on diagnosis and management. So in terms of the diagnosis of a subarachnoid hemorrhage, remember these patients are going to be coming in with a rapid onset severe headache. So typically they'll already have their CT head done in ED, and the CT head typically will show something like this. Okay, so this is a image, what we call a plain CT head, and a plain CT head, if performed within 6 hours of the onset of a patient's symptoms, or what we say ictus, has a sensitivity, okay, a sensitivity of 98.7% and a specificity of 99.9% for detecting a subarachnoid hemorrhage. So actually it is incredibly accurate. If performed within 6 hours of the patient's symptoms, incredibly accurate for actually detecting a subarachnoid hemorrhage. And oftentimes it's going to be your mainstay of initial diagnosis. It's going to be a plain CT head, and that's going to show you blood within the subarachnoid space, as you can see here. It's really, really important that you note the time of admission and you note the time of symptoms. So we've talked about this high sensitivity and specificity, but actually this declines over time. And in fact, The sensitivity from what we've described, that being within 6 hours of onset of symptoms, being 98.7% sensitivity, actually at day 5, it's 58%. So you could imagine all that kind of time that's elapsed, the sensitivity slowly decreasing and increasing and decreasing, and actually it shows you it's so important to have that CT done as soon as possible. And if the CT is not performed within 6 hours, then typically a lumbar puncture may be required to exclude the diagnosis. So when do we do a lumbar puncture? A lumbar puncture is often going to be needed if the patient has presented outside of the 6 hour window. So let's say CT is performed even within 6 hours of symptom onset, okay? If you have a CT that's performed within the window and it doesn't show a subarachnoid hemorrhage, it's most likely not going to be a subarach. And actually the risk of a query missed subarach is actually going to be less than 1.5 in 1,000 patients. And so a CT is very good and accurate for showing it. But if you don't have a CT done within 6 hours, then typically there are guidelines on NICE, and an LP is usually going to be required, okay? And in these cases, actually what you should be doing is you should be delaying the LP by 12 hours, and that's because of a number of reasons that we're going to talk about now. So does anybody know what this is that I'm pointing to? So it's a yellow bottle. Anyone have a go? Alex? No worries. So we talked about a lumbar puncture, right? So if a CT head does not show any evidence of a subarachnoid hemorrhage, then we must do a lumbar puncture, okay? And we're keeping it very, very simple and basic here. But ultimately, there are specific guidelines and minutiae. But let's just say a patient hasn't had a CT head and they need a lumbar puncture. A lumbar puncture is going to have to be delayed for 12 hours because, okay, if you have bleeding in your subarachnoid space, blood is made up of hemoglobin, isn't it? And typically hemoglobin and bilirubin, these things are not found in your cerebrospinal fluid, right? Because you don't have blood in your CSF. But if you have a bleed, particularly after a subarachnoid hemorrhage, these red blood cells that you're not meant to have in your CSF, they're going to lyse, they're going to break down, and they're going to release oxyhemoglobin because of the blood that's in your subarachnoid space, okay? So that oxyhemoglobin is converted into bilirubin, and essentially what happens is that bilirubin is going to show up as this yellow pigmentation, okay? So oxyhemoglobin itself on its own suggests a recent bleed. But then what happens is over time, and particularly in that 12-hour window that we delay the LP for, that oxyhemoglobin is actually converted to bilirubin, which has the yellow pigment. And actually, the breakdown products of your red blood cells breaking down, so your xanthochromia and your bilirubin, these are going to be discoloring your CSF, making it yellow, and essentially confirming or excluding a diagnosis of a subarachnoid hemorrhage. Does that make sense? So I'm going to talk about 4 things that are really important when you're completing an LP. The first thing is your opening pressure. So typically your opening pressure, it may be normal, but it will probably be elevated actually in a subarach. Also, number 2 is something called your red blood cell count. So because you've had bleeding in your subarachnoid space, you're going to have an elevated red blood cell count in your subarachnoid space. So it might be seen in a traumatic LP, but actually what you should be doing is you should be taking sequential tubes of CSF so that you can see a fall in your red blood cell concentration. And actually that can help you determine whether that's a true subarachnoid kind of blood in the space, or whether it's a traumatic LP. And traumatic LP just means you kind of, a lumbar puncture that's kind of caused some local trauma and bleeding in the area. And a traumatic LP is supported by a significant reduction in your red blood cells from your first and last tubes. But if you have a true bleed, then your first and your last tube is going to have a lot of blood because it's a real, true subarachnoid bleed. And so it's going to just keep bleeding. Okay, that's number 2. Number 3 is something called xanthochromia. So oftentimes you can even see this just from visual inspection, this this yellowness. But xanthochromia is a breakdown product of hemoglobin, which is obviously, part of your blood. So it may actually be detected visually, but also at 12 hours from a subarachnoid hemorrhage, 100% of patients will have xanthochromia. Okay, and it typically lasts for 2 weeks. So this is a really, really important sign, and it's going to take some time for that blood, for those red blood cells to actually break down and release the breakdown products. And hence, why if somebody has a subarachnoid hemorrhage, we often say, let's say they've not had a CT done within 6 hours, oftentimes they will need to wait 12 hours. There needs to be a 12-hour delay in order for those red blood cell product breakdown or red blood cell breakdown products to actually show. Well done, Alex. Absolutely, absolutely. So that exactly, so xanthochromia. So does everybody kind of understand, and does that make sense? Why we actually have to wait 12 hours to do a lumbar puncture after subarach? It's basically to do with us having to wait for the breakdown products of all the blood. The last thing is bilirubin. So bilirubin often you see on something we call spectrophotometry, and that is an investigation that basically detects red blood cell breakdown products, specifically, like I mentioned, bilirubin. It's a lot more sensitive than visual inspection that we do for xanthochromia, but you must remember that these samples actually need to be hidden away from light, and they need to be sent straight immediately to the lab for analysis. And bilirubin that we send off for spectrophotometry typically lasts around 4 weeks, especially if it's an extensive bleed. And so we send the samples to the lab for bilirubin. They perform spectrophotometry, and that can also confirm a subarachnoid hemorrhage. There's other imagings you can do on top of LP. LP isn't an imaging modality, but it's an investigation. But there's other imaging you could do on top of a CT head, and that's something called a CT angiogram. So an angiogram is basically a type of angiography that you inject a contrast. So it's a contrast scan. You inject the contrast, and then it shows up the anatomy of your blood vessels in your brain. And essentially, it's really important for looking for any underlying aneurysms, like we talked about. Okay, so any underlying aneurysms. The important thing to know, actually, some aneurysms may go undetected on a CT angio. So oftentimes, if these patients are really complex and they've had an MDT and they've decided actually these patients may need something called a DSA. A DSA is something called a digital subtraction angiogram, and that's actually an invasive procedure where you have an arterial puncture, typically in the femoral or the radial artery, and then what they do is they insert a guide wire through your artery. It goes straight to your brain. And what it does, it's a diagnostic and therapeutic procedure that can actually visualize your blood vessels. But what they can do is they can actually, at the time, under kind of interventional radiology, they can use various interventional devices to actually look at the anatomy and see if there is an aneurysm. And even at the time, they can use coils to basically coil the aneurysm and actually stop the bleeding even there. So that's something really cool to know. The last thing we'll talk about very quickly is the management. So the management of a subarachnoid hemorrhage, it's a medical emergency, okay? It needs urgent management. And you can split it into kind of key elements. So you've got initial management, medical management, surgical management, and aneurysm management. So the initial management is very important, and actually where a lot of the damage can happen if not done properly. But the initial management is basically assessing the GCS score. You're performing a full ABCDE approach. You're managing this patient. If they've come in as a trauma call, then you're managing as per the ATLS guidelines. And essentially, if they come in with a low GCS airway management, they're going to have to be intubated and ventilated. They'll need the appropriate imaging. It's all the basic stuff. Okay, so how you initially management. So airway, blood pressure management, blood sugar management, imaging, all the basic stuff that kind of is oftentimes maybe not always seen as the most glamorous part of neurosurgery, but is really, really important. The second thing is the medical management. So the medical management, okay, these patients need very, very, very close monitoring with close neuro observations. And on the NICE guidelines, there's a really nice set of guidelines. So it mentions things about kind of 1 hourly obs, and 2 hourly obs, and then 4 hourly obs, neuro obs, and it tells you specifically what to do. There's a really good link to that on the NICE guidelines that you can have a look at. That's really a really good read, actually. But more to do with the medical management are things such as the re-rupture. So patients need to be given analgesia, antiemetics to prevent them from valsalvaing. So if they valsalva, meaning if they cough or they sneeze, that can oftentimes increase or raise the intracranial pressure. And so oftentimes we do give antiemetics to help them from, or stop them from vomiting and increasing the intracranial pressure and actually preventing rebleeds and things like that. IV fluids are really important. So you must commence IV fluids with strict input-output monitoring. And these patients really should be in a neuro ICU or a neuro HDU. Another thing is nimodipine. So typically we give nimodipine 60 milligrams every 4 hours for 21 days from the ictus of symptoms. And that's basically, some papers say it's there to reduce the risk of cerebral vasospasm, but that's actually partially the case because there is a trial that derived that actually, yes, even though there are more favorable outcomes and a reduced incidence of vasospasm in patients that have nimodipine, actually there is a quite complex reason to giving nimodipine more than just cerebral vasospasm, which there's kind of a lot of research going into. So that's a summary of the medical management. Okay, so kind of neuro-obs, antiemetics, analgesia, fluid balance, electrolytes, nimodipine, CT angiogram, things like that. Surgical management, typically patients that present with a low GCS in the setting of a subarachnoid hemorrhage typically may have developed an emergency called hydrocephalus, which we talked about last week. So I won't go into too much details of that, but this is basically the accumulation of CSF in your ventricular system. So that oftentimes you can even see on the CT head. And if a patient has that, then oftentimes with an acute hydrocephalus, they're going to need an external ventricular drain, which is basically an emergency form of CSF diversion, where you help to reduce the intracranial pressure by draining away the CSF from the ventricles. And the aim is there not to drain the blood from the subarachnoid hemorrhage, but just to manage the hydrocephalus. So that's some of the things we could do in a surgical management. In terms of actually dealing with the aneurysm, if an aneurysm is detected, it must be secured to prevent a further bleed. It's a very, very complex decision, typically made under the neurosurgical team, but it can also be done under interventional radiology during, like what we mentioned, a DSA, so a digital subtraction angiogram. And there's two principal methods, okay? So you have, let's start with the neurosurgical one. So you have neurosurgical clipping. So that's completed by the neurosurgeons via what we call a craniotomy, which is a small hole in the skull that we make with kind of a drill. And patients are given a general anesthetic and they undergo a craniotomy and they have a microscopic assisted clipping of the aneurysmal neck. So what happens is that the neurosurgeons, they open up the lesion and they can see the aneurysm and they clip it. Okay, they clip it with some instruments and you can see some really good videos on YouTube. And that's one of the things we could do. Another choice, or the second choice, is coiling. So that's done by the IR team, so the interventional radiology team. And that's when they basically get access through your femoral artery and they go up into the aneurysm, and the aneurysm is filled with platinum coils that induce clotting, or what we call embolization, and it closes off the sac. And typically even here a general anesthetic is used. So that's something that the interventional radiologist can do for a aneurysm, okay? So either method will secure the aneurysm and minimize the risk of further bleeds, but oftentimes coiling is more commonly utilized. And interventional radiology is an evolving aspect of the medical world, and actually they are taking quite a lot of the caseload of aneurysms. We'll finish off with complications. So there's several complications associated with subarachnoid hemorrhage, such as rebleeds and vasospasms, and we've already talked about that. But the other things to know, other than rebleeds and vasospasms, and actually even hydrocephalus, like we talked about, are things such as kind of SIADH and infections and DVTs and PEs. Really, really important to not forget that actually these patients are going to get pneumonias and all sorts of chest and urine infections, even from kind of their prolonged hospital stay. So it's just important to always be aware of that, because remember, we are managing the patients here, and we mustn't forget that actually they can have many other conditions with that. So that kind of draws today's session to a close. That was a very, very brief whistle-stop tour of a subarachnoid hemorrhage, and we'll, very soon talk a bit more about specific things. So that was just kind of an introduction, a very brief introduction, just to make sure everyone's kind of comfortable with the lingo and stuff like that. But essentially what we're going to do soon is we will get to the point where we talk a little bit more about kind of the actual procedures and things like that. But that concludes today's session. We will be seeing you next week for the final talk of the neurosurgery lecture series, and that will be on brain tumors. So I'll be sure to see you guys there. Thank you very much, guys. I'll see you at the next one.